I do have much time, so I'll be skimming briskly along my slides. So this is my presentation, and this is a question that we see every day, and we meet our patients. And either this is a patient that is a de novo patient that you've just seen, or a patient that you have treated and did a cross-linking to. And there's always the question, is this patient of mine progressing or not? It's a very important question for formoplastic keratoconus, subclinical keratoconus, keratoconus suspects, or patients that do have documented keratoconus with K readings up to 55 and best corrected visual acuity over 0.5. To decide between immediate cross-linking or just follow-ups. So what is the current mainstream evidence on the subject of keratoconus progression? Actually, there's no unified sentiment all over the globe. Classically, it takes a bit of courage to mention K-max in the presence of Cynthia Roberts, but okay. So classically, most of the cornea specialists look for an increase in K-max 1.5 diopters or more, decrease in the central corneal thickness of more than 20 microns, or an increase in the Bellin-Abruzzi p-value of more than 0.42. But does everyone abide by the same rule? The answer is no. Back in the day, I think this was 2 years ago, time flies, 4 years ago, and this was on evaluating keratoconus progression prior to cross-linking. The maximum K, or the K-max, versus the ABCD, and this was a very famous, I consider this a landmark paper by Ricardo and Paulo Vinciguerra. And they found that when they used the ABCD index, that more than half of the cases showed documented progression that were not seen or were not detected without using the ABCD. So is this good or bad? Is this like an oversensitive sort of evaluation, or are these false positives? Honestly, no one knows. The definition of keratoconus progression and their impact on clinical practice has been published by the Red Cake Study Group from Antwerp, from the University of Antwerp, and they find that relying on the K-max is not reliable, and relying on two indices from the anterior surface of the cornea, again, is not reliable. And the common wisdom of using the corneal thickness and the K-max is still a little bit reliable, but surprisingly, no one uses the back side of the cornea, the back surface of the cornea, which is basically where it all starts, where keratoconus always starts. And when you rely on any index from the back surface of the cornea, combine it with front surface of the cornea, then you get the most reliable results. Again, this was the publication of the global consensus on keratoconus and ectatic diseases. Although it's a global consensus on keratoconus and ectatic diseases, it concluded that in definition of ectasia progression, there is no consistent or clear definition of ectasia progression. Again, they concluded that we diagnose progression if you have steepening of anterior corneal surface, steepening of posterior corneal surface, and thinning, which is basically a thing that we all know. But the funny thing about this, again, this is one of the very important publications on the global consensus on all aspects of keratoconus. They found that although progression is often accompanied by a decrease in best corrected visual acuity, a change in both best corrected and uncorrected visual acuity is not required to document progression. And this is something that we know, cornea practitioners all over the world, we really trust our patients in this. The patient subjectively can complain of a degradation of vision with normal tomography, and then this is like the precursor or the sign that happens before the full-blown picture of progression. And this is because of the increase in the vertical coma. So this is something that I really disagree with this paper on. And the acknowledgement of vertical coma has to be given to Dr. Alio because this was first reported, actually, it was all, coffee time chat, but it was documented in a manuscript in 2018 by his group. This is a progression score that I really like. This has been published in the European Journal of Ophthalmology by the Hospital Universitario de Cruces, a Spanish group. And the good thing that I think the very smart thing that this group did is that they subdivided the keratoconus groups into 3 different categories, and it depended on the posterior surface of the cornea. Not only this, they gave different scores or different criteria to each group. So, example, you have an early on keratoconus, which is very, very early on the scale. You should not abide by the same rules to detect or to document progression as documented keratoconus, which are moderate or even high-end keratoconus. This is a score that they proposed, and I think it's very, very smart. They depend on Kmax, sorry Cynthia, and on the central corneal thickness as well. On the higher order aberrations, RMS, and they isolated the vertical coma by itself and gave it a separate score and gave it even more score than the total RMS of the higher order aberration. I think this is very smart. Of course, biomechanical properties play a role, and there has been this group in Homburg by Professor Bertolt Zeitz and Flokerti, and they did a series of publications, and they have their e-staging system, the biomechanical e-staging system, which they incorporate, and they have very good results and very reliable results in Saarland as well. I think the future will be from artificial intelligence, and this will be our next stop. And I think in conclusion, there is no up-to-date, no current global consensus on the criteria of keratoconus progression. Relying on Kmax alone is not reliable. Again, I repeat, not reliable. Relying on the anterior curvature plus pachymetry changes is more accurate. And relying on the anterior and posterior curvature changes is more and more accurate. The addition of biomechanical parameters provides more precise gauging of progression. And of course, we need to align worldwide practice with the same guidelines. I think this is mandatory. Artificial intelligence is the only solution and is the duty of global societies. I'd like just to acknowledge my late, very good friend, is a big loss for refractive surgery, Professor Mohamed Hosny, and he was a great refractive surgeon and a great guy as well. Thank you so much.